before we talk about what's wrong in patients with pulmonary hypertension, let's talk about the normal lung so we make sure that we understand it. So this is a picture of a chest, and you can see the normal lungs are inside the chest. One thing that people ask all the time, because these pictures make lungs look kind of small, actually they're pretty large. They go basically from right where your shoulder meets your neck all the way down to about here. So they're pretty big in your chest. And we all have two lungs. There's the right lung and the left lung. And the normal lung, you can see over here, has a great big airway called the trachea right here that divides into two parts. That's your windpipe, and it divides to the right side and the left side. And then it branches, that airway does, sort of like a tree, if you will. So, you know how trees branch out and ultimately get to buds. Well, the buds on the end of the tree of your airway are called alveoli, and that's where air is exchanged or is taken up by the blood vessels in your lungs. So that's where the blood vessels take up oxygen and get rid of carbon dioxide in these little sacs called alveoli that are in the end of the branches of your airways. The diaphragms that are shown there in the bottom are the bellows that move the lungs up and down, and you can see that the heart sits here right essentially in between the two lungs. I'm okay? Okay. So that's the normal lung. So let's talk about pulmonary hypertension. Oh, one thing I should say about the normal lung is that each airway also has an accompanying blood vessel, an artery that's here in red and a vein in blue, and that's where the exchange of air takes place with the blood vessels. So what about pulmonary hypertension? The first thing that it says on this slide is it's not hypertension, which is a true thing. A lot of people come to me very concerned that they've been told that they have pulmonary hypertension, but every time anybody checks the blood pressure in their body, it's normal. So there are different things. The circulation in the lungs is the pulmonary circulation, and the blood vessels in the body are the systemic circulation. So they're just two different circulations. It's pulmonary hypertension, which is high blood pressure in the lungs, and this cartoon here is a little bit of a it's supposed to be a little bit of a joke, because I always tell people when they come in too, and forgive me, I know a lot of you have seen me in the clinic, it'd be really lovely if we could just pump up a blood pressure cuff and check the blood pressure in your lungs, but it just doesn't work that way. And unfortunately, the only way to actually measure blood pressure in your lungs is to do a heart catheterization, which we'll get into in the future. But this is sort of a picture of that we would love to be able to measure blood pressure in the lungs in an easier way. So let's talk a little bit more about the blood vessels in the lungs and what happens in pulmonary hypertension. So we had talked about the lungs. You know, there's a right and left lung, and your heart that sits in the middle has two sides to it, the right side of the heart and the left side of the heart. And the right side of the heart drains blood from your body that doesn't have any oxygen because it's all been trapped off in your tissues. And so it's blue. And the right side of your heart then pumps blood into the pulmonary artery here that's in blue. And that pulmonary artery splits. Half goes to the right, and about half the blood flow goes to the left. And it goes out to these airways that are down here and not really in this picture, where it picks up oxygen. And blood, now that it's picked up oxygen as red, goes back to the left side of your heart, where it's squeezed and pumped into your body. And that oxygenated blood goes all around to your tissues and delivers oxygen there. And that's what allows your muscles to do work like exercise. And then after your tissues have extracted oxygen from it, it comes back now to the right side of your heart as blue. So you can see there's basically two circulations that I was getting into before. There's the lung circulation and then the whole rest of the body. So they're sort of in series, not connected except for by the heart. So what happens in pulmonary hypertension? So what happens in pulmonary hypertension is that these vessels, the blue vessels in your lungs, for whatever reason, are narrowed or constricted or they're blocked. There's a whole bunch of different things that can cause it, but for some reason there's a constriction in these blue arteries, in the pulmonary arteries, and that raises the pressure. And as a consequence, the right side of the heart has to pump harder to deal with this high pressure and oftentimes dilate. So you can see this blue side of the heart, the right side of the heart, is bigger in the pulmonary hypertension than in the normal. And the left side of the heart can sometimes be squeezed by this big right side of the heart. So in pulmonary hypertension, there's a constriction in these pulmonary arteries, and also it creates a stress on the right side of the heart. So that at least should be sort of a pretty good picture of what's happening in patients who have pulmonary hypertension. What if we were to take pictures of the lungs, like little tiny pictures and slices of lungs, if we had a biopsy, for instance, and look at it under the microscope? What would people who have pulmonary hypertension's blood vessels look like? And that's what this question speaks to a little bit. So this is first a normal lung. So this is an airway, a little tiny airway called a bronchiole. And it is bringing air to these are alveoli that we talked about earlier, these little sacs where your blood vessels can take up oxygen and dump off carbon dioxide. And this is a vein here, which is where blood is coming back to the right side of, or to the left side of the heart, sorry. And this is an artery, this little tiny thing right here, which is a pulmonary artery, and blood is moving from there, from the right ventricle into these little sacs and then coming back through the vein. And you can see the artery it's small, and it's got this really thin little wall. The vein next to it's pretty big, and the artery is a lot smaller than the airway that's right near it. And those three always travel together: an airway, an artery, and a vein. They're best friends. They're always together. In pulmonary hypertension, though, this artery, so remember the artery on this one is wide open. You could imagine red blood cells flowing through there easily. In pulmonary hypertension, this is the pulmonary artery, and you can see it's all blocked up. Instead of having a nice wide open space in the middle for blood to flow through, these are red blood cells here that are all kind of plugged up, and it's a thick wall here, and it almost looks like there's an onion skin around it, we say, so we call that an onion skin on pathology. So in pulmonary hypertension, the arteries are thickened, and because of that, it makes it hard for blood to flow through them. This is a picture that a woman, Mary Furby, did for the Pulmonary Hypertension Association, and she has pulmonary hypertension as an artist and decided to make pictures of what she thought blood vessels or patients with pulmonary hypertension's various features would look like. And I thought she did a really nice job with this picture of a pulmonary artery, and you can see it looks like a spiral, or I think it looks like an onion skin. So what causes pulmonary hypertension? Well, it comes in several different varieties, and in medicine we always have a miscellaneous causes. So we won't talk about that because it's like 100 different things that are not worth remembering. So there's 4 main things that can cause problems and raise the blood pressure in your lungs. The first one that I think is pretty straightforward is chronic thrombus or clot that causes pulmonary hypertension. So if you have blood clots that are in those pulmonary arteries and just plugging up the blood vessels, blood can't flow through there, and you get high blood pressure in there. The second thing is you can have pulmonary hypertension with lung disease or low oxygen levels. And what happens in this kind of pulmonary hypertension is, say you had bad emphysema or scarring in your lungs, and it has chewed up all the lung tissue, all those alveoli that I showed you earlier. You just don't have as many blood vessels as the normal person, and that causes the blood pressure to raise in the vessels that you do have. You can have pulmonary hypertension from left heart disease. So if you look at that picture of the heart that I showed you earlier, if the pressure rises in the left side of the heart, it can cause blood to flow back into the lungs through this back pressure and cause pulmonary hypertension that way. And we call that pulmonary venous hypertension. And lastly, you can have pulmonary arterial hypertension, shown here as PAH, and that is a thickening of the blood vessels with nothing else wrong. Does that make sense? So the pulmonary arteries get thickened and look like that onion skin picture that I showed you, but there's nothing wrong with the lung tissue. There's no clots. The left side of the heart is functioning normally. and that's what we call pulmonary arterial hypertension. So pulmonary arterial hypertension by itself has also several sort of different things that can cause it. Sometimes it's idiopathic, which means that we as doctors have no idea what has caused this. It's a really fancy word to say, I just don't know. Sometimes it's heritable, so it runs in families. So there are families who have many affected members who have pulmonary arterial hypertension, and then we call it heritable pulmonary arterial hypertension. Sometimes it's pulmonary arterial hypertension related to connective tissue disease, so things like lupus or scleroderma or rheumatoid arthritis that you may have heard of can cause those kinds of changes in the blood vessels in the lungs. Other things that can do it are HIV, liver disease, congenital heart disease, and diet pills, specifically fen-phen that people took in the 90s, which is much less of an issue now, but was very common about 10 or 15 years ago. So why would a doctor ever think that somebody might have pulmonary hypertension or pulmonary arterial hypertension? And the problem is that the symptoms are nonspecific. So this is a slide that tells you about how common symptoms are as the initial symptoms of patients who have pulmonary arterial hypertension. And shortness of breath happens in about 60% of the patients, and fatigue happens in 19%. Now, in my own experience, I think fatigue is grossly underestimated here because I feel like a lot of my patients are telling me that they're really, really, really tired, and that really has been a feature of their disease since the very beginning. But you can imagine that if you went to see your primary care doctor and said, I'm short of breath and tired, the last thing that they're going to think about is pulmonary arterial hypertension. And the first thing they're going to think about is, your life is stressful, you're overweight, you have asthma, 10,000 other things that it could be that are not pulmonary arterial hypertension. But other things can be major red flags that there's something unusual about this, such as episodes of fainting or lightheadedness, chest pain, palpitations, or when you feel like your heart's racing, and sometimes that happens to patients who have PAH, and then leg swelling. But you can imagine that it's kind of hard to get to the point where you think somebody has PAH when their main complaint is I'm tired and out of breath. So that's why it's very hard for doctors to pick up that this is the problem. So it takes a little bit of a person like House to figure out that somebody has pulmonary arterial hypertension, and that's what this figure is trying to show you. And I'm not going to pretend to be House because by the time people make it to me, usually they've come with a whole battery of tests, and it's pretty clear that there's it's not just that they're out of shape and tired. So common misdiagnoses, like I said, out of shape, overweight, asthma, seizure disorder, particularly for people who are passing out. I have personally seen a couple of people be told that they had seizures. Heart failure, coronary artery disease because of the chest pain and the palpitations that people have. Heart rhythm disorders are really tragically psychiatric problems because people sometimes think that they're just making these complaints up. So why would a physician suspect pulmonary hypertension when they have all these other things that patients could be diagnosed with? Well, the first would be risk factors. So for instance, if you happen to have a family member who has pulmonary arterial hypertension, that might be a big red flag that this is something that a physician should think about. Or a patient had scleroderma or some kind of congenital heart disease. Other reasons that you might suspect pulmonary hypertension are that there's a really abnormal physical exam. So there are things that we can pick up on physical exam that I'll go over in a little bit, but there are signs, includes us as a physician, that this is more than just out of shape. And what is the sort of first investigation that should be done to address a suspected diagnosis of pulmonary hypertension? So I think probably a better way to ask this question is when somebody comes to see a general internist and they're saying they're short of breath and they're very tired, what are the first tests that a doctor might think about doing? Well, most of the time a chest x-ray would really be the first thing that they do, and if there were a abnormal exam of their heart, a doctor would also usually order an echocardiogram. And particularly if you happen to be in a family that has pulmonary arterial hypertension that's running within your family, patients who have symptoms like this usually should have a chest x-ray and an echocardiogram, because they will clue in physicians that there is something wrong if abnormalities are present. And then how is pulmonary hypertension, or the specific type of pulmonary arterial hypertension or other kinds of pulmonary hypertension that we talked about, confirmed? And it's usually by doing a right heart catheterization and also by doing a bunch of testing to exclude all those other causes that we mentioned. And I'll go through that for a second. Next. What are the risk factors that we could be considered? Well, I went through these a little bit actually already, but they include family history, connective tissue disease like scleroderma or lupus, congenital heart disease, liver disease, etc. So what are the findings that a doctor might find on physical examination that clue us in that pulmonary hypertension is present? Well, first we're looking for whether or not the right side of the heart has evidence of high pressure in it. So we're listening to the heart to listen to the second heart sound in particular, which is the valve between the pulmonary artery and the right heart, the pulmonic valve. And when the pressure is high, we say that that's a loud second heart sound. And then for those of you that have come and seen us in clinic, you know we're always pressing on your heart and saying you may have an RV heave or a right heart heave. We're feeling the right side of your heart there to see if the right side of the heart is under pressure or stress or dilated. So that's what we're feeling for. Patients often have heart murmurs, and sometimes they have a gallop, which is another sign of stress on the right side of the heart. And then the other thing that we're looking for that is really important is whether or not the right side of the heart is failing. So the other thing that patients of ours know is that we're constantly staring at everybody's neck. You have to lie back and kind of hold yourself like this because we're looking at the veins in your neck, which are essentially a direct pipeline to the right side of the heart. And when your heart is failing, those veins accumulate fluid. So we're looking for distended neck veins. Sometimes the liver can become enlarged, so that's why we're always feeling the liver over here. And we also squeeze everybody's feet and ankles looking for fluid accumulation down there. And sometimes people will have a swollen belly, so we're also feeling around there. So those are signs to us that there's not just pulmonary hypertension, but there's also heart failure associated with that. Oops. I put this in here just because I think it's interesting for people to know what chest x-rays might look like. So the one on the right is normal lungs, and you can see, like I said, they're pretty big. They go down pretty far in the chest. There's the heart in the middle, and these are the lungs in black. And you can see ribs, clavicle, and shoulder over here. And these are the pulmonary arteries here. And they're normally pretty small and sort of hard to see on a chest x-ray. And in a patient who has pulmonary hypertension or pulmonary arterial hypertension over here, you can see that the heart looks bigger than it does in the other one. So that looks like there may be the heart's enlarging because of the stress that it's under. And then the other thing to know is that you can see this pulmonary artery is not hard to find. You don't have to squint and say, what is that? This white shadow right here is a lot bigger than it is on the normal chest x-ray over there. And that's true also on the left side of the heart. So in pulmonary arterial hypertension, there's some other subtle findings, but the main one is that the heart is bigger and those pulmonary arteries are big compared to normal. So I like this slide. It says, offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. So sure, at the end of a history and a physical examination, a doctor like Dr. Pugh, Dr. Robbins, or me may have a good idea of what you have, but just to be 100% sure, we're still going to order a bunch of tests, even if you do have an arrow through your head, just to be sure that we haven't missed anything, because we are human and imperfect. It's not always quite this easy, actually. So most commonly, the first thing that we order is an echocardiogram. So this is where they rub jelly on your chest and use ultrasound to look at your heart It's just like when you may have seen an ultrasound of a woman who's pregnant, have an ultrasound of a baby in her uterus. This is the same idea. And this is a normal heart here on the right again. And this is the right side of the heart, and this is the left side of the heart. And you can see this is the right ventricle right here, and it's small and shaped like a triangle. In a patient with pulmonary hypertension, this is the right side of the heart here, and this is the left side of the heart. And we'll have an audience participation here. Do you think the right side of the heart is bigger than or smaller than the left side of the heart? Bigger, right? It's much bigger. I mean, it's huge. See, it looks like a balloon here. It's no longer like a triangle shaped like that one. And the left side of the heart, in fact, is squished because the right side of the heart is so big. So this is the left side of the heart that's tiny and hard to find, whereas the left side of the heart over there is pretty easy. So that's what we're looking for in an echocardiogram, and that shows that pulmonary hypertension is present and the right side of the heart's under stress. The other thing that we commonly get testing for is a 6-minute walk test. So this normal 6-minute walk test is you walk on a flat surface back and forth between 2 cones for 6 full minutes. And a lot of times people come to my clinic and they say, why do I have to walk? I'm very tired. I don't want to walk. And I know it is an uncomfortable and sort of unpleasant thing that you have to plan for, particularly like if you're a woman and you're wearing heels and I don't know, we make you put on sneakers. It is really fundamental for us to do this test because it tells us how much a person can do. And it's objective measure of how far they can walk. So if somebody can only walk 2 laps, that is really important information to us. And it tells us that they're very limited, whereas somebody who could walk, back and forth 500 times over 6 minutes, they can do a lot better and have a lot more functional capacity. And that distance that they can walk, the number of laps that patients can do, is a big marker of how well they're going to do in the long run. So it tells us our prognosis. People who can walk less have a much more limited prognosis than people who can walk further. And we then aim our therapy at trying to increase the amount of distance those people can walk so that we can make them better and they can live longer. So the 6-minute walk, although I know nobody gets excited about doing it, is really important for us. So like I said, we also use it to follow response to therapy. So it not just tells us prognosis right then, but it also tells us how well we're doing with treatment of pulmonary hypertension. It also can tell you if somebody needs oxygen too, which is important too. In addition to getting pulmonary function testing to look for lung tissue disease, and we also get a thing called a ventilation perfusion scan that looks for lung clots. The final way that we ultimately diagnose pulmonary hypertension is by doing a right heart catheterization. And in this test, patients don't eat anything after midnight, and they come into the cardiac catheterization lab or some other hospital setting fasting in the morning, and they have a big IV that's put either in their arm, their neck, or their groin, and after they're given a little bit of twilight sedation, the catheter is snaked up to their heart through that vessel, and then it's basically snaked further on into the pulmonary arteries where pressure is directly measured in the pulmonary arteries. And it measures, so in here you can see that this catheter is shown as yellow, and if there were a video, you'd see it's sort of snaked in like this. It's got a balloon on the tip of it that brings it through the right atrium and the right ventricle into the pulmonary artery, where it sort of sits down here and measures the pressure directly. So it's not on the left side of the heart for pulmonary hypertension diagnosis, it's just on the right. So pulmonary hypertension diagnosis really requires a direct measure of the pulmonary artery pressure and the resistance, and it can only be done by a heart catheterization. And you have to exclude left heart disease that this heart catheterization can do for us. And the values that we're looking for to say that pulmonary hypertension is present is to have a mean pulmonary artery pressure that's 25 millimeters of mercury or greater. Now, Normal pulmonary artery pressure is about 15 millimeters of mercury. So it is substantially higher than normal pressures that we use to define pulmonary hypertension. And then the wedge pressure, which is a marker of how much fluid you have in the left side of your heart, has to be 15, which is not an important thing for you all to remember, but it is sort of something that I spend all my life thinking about, is what exactly is the wedge pressure. And it's just a marker of us excluding left heart disease. So the right heart catheterization excludes left heart disease, that pulmonary veno-occlusive or pulmonary venous hypertension, and also tells us exactly how high the pressures are in the pulmonary arteries. So to diagnose pulmonary hypertension, you have to do a right heart cath. And then at the time of the heart catheterization, we also test out special medicines and fluids and see how your heart responds to them. And that tells us what kind of treatment may be useful for patients who have pulmonary hypertension. And so that's basically what we use also to guide our therapy choices. Let me turn this off. So we also do blood testing to look for people who might have connective tissue disease that we didn't suspect on history or physical examination, to look for liver disease or HIV infection. We do, as I mentioned, lung function testing to look for COPD or lung scarring. And we get a perfusion scan or a chest CAT scan to look for clots. And sometimes if we're concerned about sleep apnea, we'll order a sleep study. So this talk was basically to talk about how pulmonary arterial hypertension is diagnosed and how other forms of pulmonary hypertension are diagnosed. And the next one sort of goes through treatment. Does anyone have any questions?
Our family doctor thought it was a high blood pressure issue, and when he put him on the medicine, it caused him to really feel real bad. And he had lots of, along the way beforehand, he had throwing up, and he had stomach problems.
Problems too. And sometimes the medicine that we use to treat pulmonary hypertension or other medical conditions can irritate the liver. That's another thing that happens sometimes.
As soon as they took him to Centennial and started running some more tests, they told us right away he only had 3 days to live.
Oh gosh, I'm sorry.
And we didn't even know that he had this problem.
When they did the echo, it didn't show my heart enlarged, so then it just became an issue that was in my head, just because it was familial and I'm just thinking about it all the time, and that was what was going on. I think you just really have to push it with your family doctor that this really has to be checked if I'm doing all this another way. And actually I went a year just because that was exactly what I wanted to hear, that I didn't have it.
Yeah,
and it took
that's hard.
the year, it took a year, and then I went back because I started passing out, and then by then my heart was enlarged.
Yeah, I think that especially for patients who have pulmonary hypertension that runs in families, you're aware that this is something that you need to be worried about, and so it's easy to say to somebody, this is all in your head, but a lot of times it's not, and being your own advocate is so important, to go back and say, I'm not right, I know I'm not right. If you look in recent publications from the United States that look at thousands of patients who have pulmonary hypertension, it takes on average more than a year and a half for people to get diagnosed. So it is, in fact, normal to have to talk to your primary care doctor or patients or other doctors that are consulting and say, look, there's something not right here. We are working very hard to educate doctors so that they understand that this is something that they need to be thinking about and looking for. But that education just takes years and years, and I don't think that it's widely known, across the physician community that this is something that we need to look for in patients who are complaining of shortness of breath and fatigue that would otherwise just be blamed on, like, out of shape and tired.